There we go. Okay, thanks, team. So, oh, no, I'm just going to scoot up. There we are. Thanks for your patience. Birth trauma. There is no internationally recognised definition, but at Birth Trauma Aotearoa, we understand birth trauma as any physical or psychological trauma experienced in relation to pregnancy, labour and birth, or the postpartum period.
Just sorry to interrupt.
Yes.
We're seeing the fifth slide, the birth getting it right slide. We're not seeing the slide you're working from.
Thank you very much for letting me know. It's come up on my end. Angela, can you see the intro slide or?
No, I'm seeing the last slide as well. Have you got a split screen?
Yeah, I think
I've got two computer screens.
And,
oh, sorry, Jane. Let me try going up here.
There you go.
There she blows.
That's right. Yeah.
Zoom, mate. It's a wonderful thing. All right, let's start again. No internationally recognised definition, but at Birth Trauma Aotearoa, we understand it as any physical or psychological trauma experienced in relation to pregnancy, labour and birth, or the postpartum period. So around 80% of birthing people will sustain at least a mild physical injury, and 1 in 3 births will be considered as psychologically traumatic by the birthing parent. In Aotearoa, this equates to around 50 women per day leaving birth emotionally traumatised, which I just find a staggering statistic. Birth trauma is often not simply about what happened, but also, and often more so, how we feel about what happened. So Carel has done a bit of work in the birth trauma space, bit of research rather, and she noted this in her 2004 article, where she said that birth trauma is in the eye of the beholder. Importantly, for health practitioners to understand, a clinically positive birth can be experienced as hugely traumatic for the parent, and similarly, a clinically traumatic birth might feel totally fine to a parent. Aotearoa-based research regarding birth trauma is currently sparse, though it is quietly growing. And one early project that I often refer back to was undertaken by Carla Sargent. Now, Carla is not an academic, but an ex-midwife, and she established Aotearoa's first birth trauma-specific counselling service. So Carla holds very deep understandings of birth trauma in this country. Carla's 2015 report outlines the responses of 319 women who generously shared their experiences. And these respondents could choose multiple causes for their trauma. And the results from this study suggest that the most common causes of birth trauma were fear surrounding the outcome of the birth, also feeling robbed of their desired birth experience, fearing for one's own or baby's life, and around kind of the 50% mark was poor care, excuse me, from a midwife or doctor, poor pain management or physical injury, having baby in NICU, and then surprisingly the least common reported causes were baby death or disability and the triggering of past abuse. So these trauma themes are again echoed in the work of Carel, whose research looks specifically at post-traumatic stress disorder in New Zealand mothers as a result of their birth experience. Research suggests that post-traumatic stress disorder impacts around 4 to 6% of mothers post-birth, though I would actually argue that PTSD symptoms would be present within the day-to-day experience of many more mothers than this, even if these symptoms are not severe enough for a PTSD diagnosis. Much of how we feel about our birth is relational. That is, it's about the interactions that we have with healthcare staff. One of the strongest kind of threads that weaves through much birth trauma prevention, birth trauma occurrence, and certainly birth trauma healing is our relationship to those who are caring for us. And again, Carel Beck's early work highlights this. The interactions between birthing parents and those caring for them directly influences birth experience. These interactions can also have a huge influence on the wider whānau, as we need to remember that there is often another parent or support person in the birthing space, and many non-birthing parents also experience birth trauma. To emphasise the need to be mindful of the interactions between healthcare staff and birthing whānau, I'll just share a brief story from a father's perspective. So John's partner's pregnancy had been smooth, but the birth was long and tough. Upon the birth of their baby was rushed out to NICU and John's wife started hemorrhaging badly. As they hastily wheeled his wife out to surgery, a nurse called back to John, "She's not coming back." The nurse meant not coming back to this room. John thought she meant his wife wasn't coming back at all. John was left in a bloody room with no baby, no wife, and no clue as to what was happening to either of them. And no one came to check on John for over an hour. This story also highlights the need to mind our language. The language used and shared with mothers can have a huge impact on their mental well-being. And a recent report by the UK's Royal College of Midwives highlighted this, and I was pleased to see a recent Stuff article outlining this research. We need to ask ourselves whether terms such as incompetent cervix, poor maternal effort, and failure to progress are the very best that we can do, and whether we are conveying the best possible messages via the language we use. If we are talking about consumers' experiences of interactions with staff, I think we also need to consider the systems under which these staff are working and upon which health consumers are relying. I'm sure you all understand the impact of embedded racism, ableism, heteronormative attitudes, and urban-focused decision-making, and how these impact from the system level right down to day-to-day interactions between staff and consumer. This is a topic that probably warrants a whole nother hour discussion, so we'll just leave that simply flagged. At the heart of many traumatic birth experiences is consent, or rather the lack of consent gained from the birthing person. The birth trauma community often reports very low rates of true informed consent, where we understand the benefits, risks, and alternatives of interventions and decisions.
Could I just interrupt? Sorry,
yes.
one more time. You'll need to remember to advance your slides so we see what slides you're working from. I think you're on your third slide now, perhaps, about consent.
It should say consent, yeah. Is there a lag or is it not coming through for you?
I think you'll need to click on that slide, that consent slide on the left, perhaps. The number 3 slide. We're just seeing birth trauma intro.
We're still at the top.
Sorry.
Yeah. It's fine.
What about if I go,
Yep, there we go. Yep.
That's very odd. Sorry. I'll try to remember that, but please sing out if you don't get what should be there. So, comments we hear really regularly within the birth trauma community. These include things like, they didn't tell me, I didn't know, they didn't ask. They didn't tell me they were going to do that to me. I didn't know this could happen if I had X, Y, or Z intervention. They didn't believe me when I said I wasn't ready to push. And very, very common, I wasn't listened to. These kinds of comments by mothers often also refer to physical injury as well as psychological harm. Obstetric violence and obstetric rape are considered as occurring whenever consent isn't obtained. An example being a stretch and sweep procedure done without the mother being asked, without her knowledge that it's going to be done, and certainly without her having any idea about risks, benefits, and so on. And you may have seen a recent news report on this procedure being performed on a labouring woman without her knowledge or consent. I'm sure we've all heard the term leave your dignity at the door in relation to birth. And I wonder why birth needs to leave the consumer void of dignity. This common phrase also points to the idea that mother is superfluous to the health of baby. And members of the birth trauma community often report the use of coercion in the birth space. So comments such as, you do want baby to be okay, don't you? Or All that matters is a healthy baby. Or if we don't do this intervention, then baby will die. Some key questions arise from this for me. Did that slide flick over, or shall I go and do that other trick? No? Thank you. Have you got me or just mum? Grand, thank you. Key questions for me. How can healthcare practitioners communicate information, urgency and emergency better? Also, consent is central to human interactions outside of the birth space. So why is it not held to the same importance inside the birth space? And when does mother or birthing parent stop being important and become merely a vessel for a healthy baby? The idea that mother no longer matters can also be felt strongly post-birth. When expressing distress or pain or need, we are often met with attitudes such as, well, all that matters is that baby is okay, or at least baby is healthy, and what did you expect? It's birth. These attitudes, while often pitched as a silver lining and often, expressed out of kind of people trying to show love or support, they're actually dismissive, and they put up barriers to people seeking support and care. Simply, if we, the birthing community, face these attitudes when expressing distress, we'll just stop talking and not reach out for support, as we are so often encouraged to do when it comes to mental health. The interactions between staff and consumers post-birth can be just as important as those used during labour and birth. So language used, time spent, care, empathy and gentleness and trust in the relationship with carer can again have a huge impact on whether the parent has a positive or negative post-birth experience. Further, postnatal checkups often focus on the health of baby, and while this is obviously hugely important, a growing body of literature, for example, that's in Koitu up in Auckland, this literature tells us that if mum isn't okay, then baby is less likely to be. Women often comment about this. What about me? I'm in pain or really uncomfortable or really not coping, and nobody asked how I was doing. And sadly, birthing parents still come up against dismissive attitudes that gaslight. My own post-birth experience, when I expressed concern over a physical matter, the conversation ended very quickly when I was told by the GP, well, things move around during pregnancy, no further questioning, no referral, no testing, that was it. So find that last slide for you that you've seen already. There we are. What's the ideal? What is on our wish list for birth-related experiences? Aside from the practical call for a fully funded maternity and wider healthcare sector, we would also like to see the wide use of trauma-informed care, also mother and birthing parent and whānau-centred care, where the birthing parent is listened to and held as the expert in her own body, her baby and her health. Care where relationships between consumer and practitioner are central so that trust can form and consumers can feel safe. And lastly, easy access to equitable and safe support following birth. If we get it right for birth, we get it right for a lot more than just the birth. And I'm certain we will see not only a reduction in birth trauma and harm, but also positive changes to our communities more broadly. Kia ora koutou, thanks for your patience with all the technical bizzo. I'll hand it back to Angela.
Kia ora, thanks, Kate. All right, let me see. Yeah. Cool. Displaying slightly strange on my screen, but is that all right for you guys? Yep. All right, great. Okay, I just wanted to make a quick comment here before we start as well, acknowledging two people, Alicia Coram, who's a colleague of mine in Melbourne, who helped work on kind of my version of the slides for a previous talk at ABLE, a version of that, and also Ben Gray, from whom a lot of the work I do on, or the work I use on trauma-informed care has come from Ben. Thanks. Okay, I'm going to skip through these. I had Kate's slides there in case we needed them. Right, so Kate mentioned that part of the trouble here is a kind of lack of settled definition. That is true, and that speaks to some of the kind of epistemic justice problems, particularly hermeneutical injustice, which I'll come to. But broadly speaking, a definition in the academic space that is gaining traction is that proposed by Greenfield and colleagues a few years ago. So birth trauma happens when the emergence of the baby from its mother occurs in a way that involves events or care that cause deep distress or psychological disturbance, which may or may not involve physical injury, but results in psychological distress of an enduring nature. And in the academic literature, is in line with, as Kate said, recognition that birth trauma is subjective and can vary from a clinical assessment. So clinicians might think the birth has been really straightforward, but a birthing person's experience of that might be quite different. Trauma more generally is characterized by sensations of powerlessness, danger, and loss of control. And that results in intense anxiety and feelings of helplessness. Trauma is sometimes described as a highly activated, incomplete biological response to threat. And it can feel like you're frozen in time. And so often people switch between kind of obsessive thinking about the event, which is when they're trying to process what happened. And then when their psychological reserves sort of become overwhelmed by that, it can flick into kind of disassociativeness, loss of memory, and kind of ignoring the process, and then kind of switching back and forth between those quite extreme responses, trying to make sense of the experience. Generally speaking, birth trauma is poorly recognized in the literature. It's underdiagnosed in practice. It's often misdiagnosed, for example, as postnatal depression. It's insufficiently treated, and it's under-researched. And we can see that play out in kind of a couple of different ways. It's only actually relatively recently been recognized as a concept itself. So if you look at the literature around birth trauma, birth injury, the vast majority of that is about injury to the baby or trauma that occurs to the baby. It's only very recently that psychological trauma for the birthing person has been acknowledged. In the literature, there's really unsettled and variable terminology, which makes it exceedingly frustrating to try and navigate. So terms include like negative birth experience, traumatic birth, which is different from someone having a clinically diagnosed post-traumatic stress disorder. It's tied up often in the literature with anxiety, postnatal depression, and birth injury. And there's a real lack of clarity in the literature around kind of what the causal relationships are. So some of the literature tends to assume that actually all trauma occurs as a result of birth injury. And if we can just address the physical injury, that will reduce the risk of birth trauma. So the literature itself is kind of very unclear. And I think this contributes to women's, providers' lack of awareness of the risk of birth trauma and women's difficulty in getting diagnosis and help after the event. So sort of as Kate alluded to, this has been really big in the media in the last week, particularly in Australia. So this is a parliamentary inquiry in New South Wales, started in response to Naomi Bowden, who had a very traumatic birth and a stillbirth. And so she raised this issue, which led to the parliamentary inquiry. They had 4,000 women submit stories in 6 weeks, which they found really overwhelming and surprising. And some of the kind of narratives here have been generally those 4,000 testimonies referred to birthing people or mothers who say they were ignored, belittled, and denied the opportunity to give informed consent. So kind of what we're hearing in Australia is very similar to what Kate's heard from whānau in New Zealand. And real focus on consent as well. So Hannah Dalen, who's a professor of midwifery in Australia, says no means no, except apparently in childbirth, and it's time to change that. This has been described as the Me Too moment for birth in Australia. So this is a paper from just a couple of days ago. So it'll be interesting to see if this, I think, gets picked up in any way in relation to this debate in New Zealand. I think Kate sort of covered much of this. Generally speaking, the literature sort of outside New Zealand well, this is one kind of global online survey which found 4 themes regarding birth trauma. So one was prioritizing the care provider's agenda. So feeling like the woman's birth was aligned to the care, whether that's the midwife or the obstetrician, what their schedule looked like, when the anaesthetist, might be available. People gave stories about, having cesareans because the obstetric consultant needed to leave work and go and play golf, for example. It's a really strong theme of disregarding embodied knowledge. So hospital staff not listening to me and not trusting me to know my own body. A theme of lies and threats, and certainly, as Kate said, being bullied or coerced and being threatened with harm to the baby. And a sense of violation. So this was a really, this was a person sort of describing their experience of birth. The most terrifying part of the whole ordeal was being held down by 4 people and my genitals being touched and probed repeatedly without permission and with no say in the matter. My daughter's birth was more sexually traumatizing than the childhood abuse I'd experienced. So these are kind of obviously quite extreme experiences, but as we're hearing in Australia, and as this kind of online global survey found, women experience their birth as traumatic much more often than we recognize, and that's a real problem. So I suppose from a philosophical perspective, the 3 things I want to offer in today's talk are 3 concepts and how they apply to this area. So these relate to epistemic injustice, and so here I'm working on Miranda Fricker's 2007 work on epistemic injustice. So epistemic injustice generally is harming or acting unjustly or unfairly towards someone, so specifically in their capacity as a knower. So the idea here is that knowledge is power. When our knowledge is recognized and when we are recognized as sources of legitimate knowledge, that is a way of respecting us. It enhances our dignity and it gives us power in a social space, right? Because we can contribute our knowledge, and to some extent, which versions of knowledge get amplified means that some of us get to create the social constructs which inform how other people's knowledge is seen. So knowledge is power. There's 2 types of epistemic injustice, and I think both of these relate to what we've heard from Kate about birth trauma in Aotearoa. And then the third is wrongful depathologization, which I'll come to in a minute. So the first 2 are testimonial injustice and hermeneutical injustice. So this is both from Fricker's work. So testimonial injustice is a little bit easier to understand. That's the downgrading of the credibility of a knower, and often as a result of prejudice. So the idea here would be that patterns of racism, sexism, ageism, or other forms of oppression and discrimination mean that we discount certain people as social knowers, and we don't recognize the knowledge that they bring as legitimate sources of knowledge, right? So debates around te ao Māori, for example, and to what extent that counts as like legitimate knowledge feed into this kind of space around testimonial injustice. So all the literature that that Kate was speaking to feed really clearly, I think, into this idea of testimonial injustice. And I'll talk about that a bit more in a minute, but let me just first introduce the idea of hermeneutical injustice. So this happens when a significant area of one's social experience is obscured from collective understanding, and this results in the person struggling or failing to articulate their experience, both to themselves and to others. And so it means that people don't have a framework for understanding conceptually what's happened to them and or being able to communicate that to other people in a social context. And both these forms of injustice are seen as both harmful and wrongful. And they're wrong because they harm people's agency, their dignity, and their identity as knowers, and their ability to collaborate in the social production of knowledge. So testimonial injustice. As we've heard from Kate, the current claims of women not being listened to, being dismissed when presenting knowledge of their experiences. Some people refer to this as medical gaslighting. So research by Dawes very recently says a striking feature of women's narrative was how common it was for women to be dismissed or not believed when reaching out for help, a phenomenon sometimes described as medical gaslighting. Other research suggests that people by health providers have been labelled as fussy, hysterical, or exaggerating their pain, for example. So these kind of dismissive attitudes harm women as knowers. People talk about feeling invisible. This again reflects Kate's view that the focus is on the baby, not the woman. The hospital staff discussed my baby's possible death in front of me and argued in front of me as if I just wasn't there. And so this experience is a downgrading of credibility, and it's plausibly linked to prejudice connected to social identity as women and as mothers. So some of the social framing around mothers and the socially expected role of mothers to be in service to their children contributes possibly to this failure to recognise mothers and to weigh mothers' knowledge and experience of birth as important as the experience of and the health of the baby at that moment, and also regarding women. So a lot of literature suggests that women generally are undertreated for pain. Their pain is more likely to be dismissed as hysterical by health providers. So one study, for example, looked at how long it took for women and men in emergency departments to be treated for their pain, and women typically had to wait longer than men in equivalent situations to get pain relief. So using Miranda Fricker's account, I think there's plausible sort of social prejudice around mothers and women, which might contribute to the test and partially explain the testimonial injustice that's occurring here. Hermeneutical injustice occurs when we don't have a concept to explain our experience. And so, for example, I'll just give you a couple of examples. So, for example, the idea of like marital rape. Before we had a concept, socially or legally, of marital rape, there was no way of explaining the harm that women experienced if they were raped inside marriage, because that simply kind of didn't exist in our social consciousness. Fricker gives the example of sexual harassment, again, like in the workplace. Women might feel really uncomfortable about that, but not have a recognized framework for communicating it. I would say more recently, acknowledgement of things like racist microaggressions, again, fall into that category. Before we had that concept, people often said that there were lots of little things that happened in their daily life that didn't kind of look like harassment or racism or discrimination, right? But still were really challenging and upsetting for them. We didn't have a framework to talk about that. And in the work that I do with the medical students on unconscious bias in medicine, often what's really striking to me is that students come up to me afterwards and say, that was just so helpful because it gave me a framework. You know, I had this student a few years ago who was very tall, fourth-year student, and had a British accent. And he said, I had this experience, I've just been on geriatrics, right? And I stand at the back of the room, and in front of me are often, 6 shorter women, because there's a lot of female consultants in geriatrics. So there'll be the consultant, and then the registrar, and then the house officer, and then me. And I'm trying not to make eye contact, but nonetheless, patients will look over the head of all of these senior people and direct all their questions to me. The lecture was just having a framework to explain that experience to myself, right? So the value of these concepts in terms of our social understanding of our own experience and our ability to communicate that, I think, shouldn't be underestimated. So partly what is the failure to have a clear definition. And so when I talk about like the messiness, that is an example, I think, of hermeneutical injustice, because we haven't got kind of a clear concept. The failure, for example, to do for providers to be aware of the extent of the problem, the failure to do screening for trauma after birth, again, is like just a lack of this concept working in the birth space. Another way of looking at this, and this kind of links into what I'm going to say about wrongful depathologization in a minute, is part of the reason we don't have a concept is the extent to which birth is being normalized. And this kind of fits into this focus on the narrative of the baby's health, right? So again, quoting from Beck, because the birth was seen to be successful because the baby came out well, the experience of the woman is de-emphasized. So I was congratulated for how quickly and easily the baby came out, and everyone was so pleased about how well it had gone, but I felt as though I had been raped. If we look at DSM definition of post-traumatic stress disorder, that is so PTSD is the actual threatened death, fear of an actual threatened death or serious injury, or threat to the physical integrity of the self or others. Now, up until 1990, part of that clinical definition required that the threat be something outside ordinary experience. And the examples were given were like being assaulted in the street, or experiencing war, or some kind of catastrophic event like the Christchurch earthquakes. Because birth was normal, right, and an everyday experience, it was actively excluded from the definition of trauma for a long period of time. And so that again feeds into this idea of hermeneutical injustice, because we don't have a concept to describe women's birth trauma. So that leads us into wrongful depathologization. So this is work by Lucien Spencer and Harvey Carel quite recently, and they're based in Bristol. So they say another form of epistemic harm occurs. They're talking specifically about psychiatric disorders, but I think we can use it a bit more broadly than that. When a disorder is simultaneously stigmatized and trivialized, and they, for example, refer to OCD as this example, where on one level it's sort of trivialized because people are like, everyone's a little OCD sometimes, aren't they? But at the same time, it's stigmatized in the way that we stigmatize many mental health conditions. I think kind of moving out of the psychiatric space, this is actually a really useful concept in a range of areas. If you think about something like hazing, or kind of like initiation experiences, or bullying in boarding schools, for example, a lot of that is both simultaneously stigmatized and trivialized, right? So it's trivialized because everyone's been through this and it's no big deal. And it's also stigmatized because if you experience it as really distressing and harmful, you're sort of seen as taking it too seriously. And so I think this is also helpful in understanding some of the epistemic barriers we've got thinking about birth trauma. And that's, again, simply because it's normalized. And people say, you expected some pain, didn't you? And I think even when I think about my own birth, particularly, so I've had 3 children, my first birth, it was only when I started doing this work with Kate that it even occurred to me that some of the experiences that I'd had, might be classified as traumatic. So I had an experience of not being in my body anymore and floating around on the roof. And when my daughter was born and they put her on my chest, my mum was saying to me, she's here, she's finally here, look at her. And I was trying to say to her, I'm not here. I'm not physically in my body, so I can't look at her at the moment. And it's only when I looked at this literature that I was like, oh, right, that's a form of disassociation. That's interesting. And so I think, even our own experience, we can simply say, oh, well, obviously birth's difficult. And so downplay some of that potential trauma response. Anything else to say about that? The other example, I suppose, here in terms of wrongful depathologization relates to, and I'll flick over to the next sentence. I think everything there I've covered. Okay, is in relation to ACC. So this is super interesting, again, I think from a conceptual perspective. So really exciting that ACC is now covering birth injuries, but also the fact that this has happened in 2022 also suggests, we might have lacked a clear clinical concept of trauma and birth injuries up until then. Now, from ACC's perspective, one of the barriers to getting them to recognize birth injuries, and note here that they're only covering injuries and trauma that results from these injuries, they're not covering trauma that isn't associated with one of these 9 physical injuries, was that the definition of injury for ACC was harm caused by something external acting on the body and causing an injury, right? So you are bouncing on the trampoline and that trampoline causes your injury, or you fall over and hit your face on the road and that's an injury. But the baby was defined as internal to the mother. So the baby couldn't cause an injury when exiting the mother's body because it wasn't an external force acting on the woman. So I think there's lots of really interesting kind of definitional and conceptual things that have gone on in relation to medicine that limit our epistemic understanding of the harm of birth trauma. So I'll leave it there in terms of my discussion of those three things. So that was testimonial injustice, hermeneutical injustice, and wrongful depathologization. And just before I finish, I just want to do two things. One, talk about moving forward and what can help, and then talk about activism and bioethics. So where to from here? You know, a lot of the work that Kate has done with women and families focuses on communication, the value of communication, and consent. And a lot of the international literature does suggest that much birth trauma is actually preventable, right? So it's not the case that there's some kind of catastrophic, very complex, very high risk birth that was just unpredictable and unforeseeable. Most birth trauma is thought to be preventable, and that's through better relationships and communication, better pain management, and appropriate staffing levels, right? So that staff aren't under stress. I think there's kind of interesting work to be done there around like consent and how much we can consent up front, and how much we can do consent in the process when women are already obviously under a lot of pressure and distress. I think taking that idea about consent and looking at it through a trauma-informed care approach is quite useful. So I think it's helpful to think about framing all birth from a trauma-informed care perspective. Now, so as Kate said, a third of women experience their birth as traumatic. 4% have PTSD, but that 4% goes up to 19% in high-risk groups, and those high-risk groups are often groups that have experienced previous trauma. So trauma-informed care really focuses on like safety, relationship, and trust. So the 5 principles of trauma-informed care are safety, choice, that would lead into the question of consent, empowerment, trusting relationships, and a sense of collaboration. And so Ben often says, I hope I'm not going to get this wrong now, Ben, the difference in trauma-informed care is, instead of saying to a patient, you know, what's wrong with you, you ask like, what's your story? What's going on with you? And it's really about treating the person as a whole patient. Now, come back to consent. There are a lot of things, you know, some things that might happen in an emergency context that might move very quickly, and there might be less time for consent in the moment. But there are lots of things that we can really proactively do, and that's about informing women before they go into the birthing process more accurately, and really focusing for people where choice and control is really important. What things can they in advance specify that they want control during that birthing process? So for example, it might be, it's really important to me that you always ask permission before you touch me during this process. It's really important to me that I know the name of everyone who's in the room, right? So when anyone comes into the room, please introduce who those people are. I don't want to have medical students or nurses, for example, during this process. There's specific trigger words that I would find really upsetting. Can we please avoid those? So I think there are ways we can think really proactively about where we can respect women's choice and agency in this process. I think it's important to provide additional training regarding some of these issues around epistemic injustice, social hierarchies, and social identities and for medical students. We do that kind of more in the medical program now. And this sort of training is around thinking about reflexivity and epistemic humility. And I know John did a talk on epistemic humility not that long ago. But the challenge with epistemic injustice is really a overvaluing of certain types of knowledge, in this case, clinical knowledge and experience, and an undervaluing, a lack of credibility for women's embodied knowledge around what's happening with their body. So it's kind of being really intentional about shifting that balance and making more space to actively listen to women in this space. Okay, and then one last thought. This has been, this last couple of years' work with Kate has been really fun from the perspective of thinking about bioethics and activism. So for those of you who are sort of interested in this more broadly, I just wanted to point you to this interesting special issue of Bioethics from 2019, which has a range of great papers about the intersection of activism and bioethics, and to what extent that's necessary. Draw Drawing on earlier work, Francois Baylis and Alice Drager have argued that when you're working in fields where there are recognised injustices, it is expected as part of the knowledge required for being a professional. Sorry, working in fields where recognising injustice, right, sorry, okay. So they're saying in bioethics, there's a lot of focus on justice. And so part of what we're expected to know is that those injustices occur, right? So that's core knowledge for our profession. But it's not just enough to aim at being a competent knowledge producer. There are possibly also attendant duties to act where possible on this knowledge in a committed and sustained fashion, right? So as bioethicists, is it sufficient for us just to kind of describe these injustices, or is it actually part of our professional ethical duty to actively try and change the world and how things are done? And I was taken by Aisha Ahmed's comment in her paper in the special issue that when you're doing research, for example, in global health or with vulnerable communities or kind of on humanitarian issues, doing this research almost invariably carries an urgent need to address oppression and inequality, and it can feel like a personal obligation to press for change. And so it's been a nice opportunity for me kind of working with Birth Trauma Aotearoa to think more strategically about how we kind of actively make change happen in this space rather than just kind of writing academic papers on it. So I will leave it at that for now and stop sharing. Hopefully we've got time for questions.
Thanks, Angela. Yeah, we have 15 minutes left for questions.
Okay.
So for those of us joining via Zoom, if you're able to use the raise hand function on the reactions tab on Zoom, if you'd like to ask a question. And those joining us in the Bioethics Centre can use the old-fashioned method of hand raising for questions. So I'll open the floor for questions.
Can I go?
Yes.
Yes, Josie, go ahead. Thank you.
I just have a definitional question because initially it sounded like birth trauma would be reaching, sort of include prenatal care and extend to postpartum care, but then there was one of the definitions that you used that seemed much narrower, to do with just the process of actually giving birth. Like I think it was to do with something like
Exiting the body.
Yeah, something like that. Right. That seemed you know, like not even the whole birthing process, but just the bit where you actually are giving birth in the kind of strict sense. So I just wanted to just hear a little bit, because it seems like I would assume you lose. I felt like you were favouring that, surely it would favour the former, but I don't know what's at stake in that choice.
So I think the definition I use is a definition that's getting traction in the literature. So I suppose that comes back to activism versus academia, right? So that narrow definition is getting traction, I think, in the literature, but I think Kate would recommend a much broader definition. So again, like that's sort of part of where the definitional space is up for grabs at the moment. Kate?
Yeah, I certainly include the full kind of spectrum of experience in relation to birth at all. So right from conception. So people who have fertility challenges, for example, I consider that, you know, we need to be thinking about that. Partly because, for example, someone who does have fertility challenges or has a really challenging postnatal experience, where else is that experience and that need going to be captured? So yeah, I take the kind of review because it's kind of all the same stuff, if that makes sense, in a way. And people they have the same need, they need the same support. But again, that's challenging, because if you look, you know, if you're wanting to do research or make policy change or programs or what have you, you need to have it really tight, a tight definition. So that's a bit of work for us to do, I think, in the birth trauma, you know, kind of NGO space, is to make those definitions really tight. So we're on it, but we haven't got there yet. Yeah.
Thanks both. Ben, go ahead.
Kia ora both. It was great. One comment, I would be interested in your views on Bessel van der Kolk's book, which covers The Body Keeps the Score around trauma-informed care, particularly is very critical of DSM diagnoses. And since I've thought about birth trauma and thought about trauma-informed care, the whole idea that there is such a thing as postnatal depression doesn't really make any sense to me anymore, in that surely these are women who've experienced birth trauma and are overwhelmed as a result of it. And, you know, it's not a helpful thing to suggest that there's some chemicals in their brain that need to be fixed.
You know, I've long since had a research project that I would love for somebody, hint, hint, nudge, nudge, to pick up. And that's around essentially the misdiagnosis of trauma, of birth trauma, as PTSD, as PND, so postnatal depression or postnatal anxiety. I think that in the postnatal space, for example, a woman presents to her GP and says, look, I'm really struggling, I'm really teary, or I just can't focus, or what have you. The GP or other professionals, for example, you know, midwives, plunket nurses, they're just not asking the questions. And that's part of my job as an organisation in Aotearoa, is to encourage those frontline health care professionals to ask about birth, and to say, you know, to say to women, how was that for you? Like, before they go down the kind of diagnosis track of PND, saying, how was that for you? So they've got it, the healthcare staff have it in their mind. We need to think about birth. We need to think about whether this actually is depression or anxiety or what have you. And could it be related to the birth experience? So if anybody's keen to pick up that project, I'd love to chat.
And I think, yeah, I mean, one thing we know is that it often takes women a long period of time, and often possibly by other misdiagnoses, to get a diagnosis or recognition of birth trauma. And again, like, part of the irony of what's really tricky here is that often for women, that traumatic experience is associated with a hospital or a clinical setting, and or specifically their interactions with health providers. And then who are they supposed to go to if they're feeling distressed? Health providers. And so that becomes this kind of double barrier, right? Because we know with trauma that part of what's difficult is going back to the kind of traumatizing context or environment. So if you were traumatized at the hospital, but you're going back for your checkups at the hospital, that can increase anxiety and might actually kind of create barriers to getting help as well. And to that point, you know, often by the time women are starting to reflect on the fact that they really think there's something here that needs attention, it might be some period post the birth. And as Kate says, if we're not kind of actively thinking about that as a potential trigger, it can be missed.
Just quickly following on from that, part of our job at the moment as an organisation is to essentially get the idea out there that birth trauma happens. And a lot of our work at the moment over the last kind of year or so, and probably for the next 5 or 10 or maybe even longer years, is just bringing the concept and the experience of birth trauma, the fact that it might happen, to the forefront of people's minds. Because unless we know it happens, we can't make changes, we can't treat it, we can't diagnose it, we can't, you know, make changes to prevent it. So it's important.
Got a question here in the room.
Thanks, Kate. Yeah, go ahead, Grant.
Well, I know nothing about this area, and feel very humbled by what you said, so thank you very much. But it does articulate with a much broader topic, which is totally undeveloped in the biomedical psychological literature, and that is top-down control of our neural health or status. I mean, we have so long pursued a program where we're looking from bottom up. What's the basic natural causal origin of this psychological state, among which drug treatment has become, of course, very dominant. But as soon as you start looking from top down and realizing how much a person's overall orientation to the world and to other people and to themselves actually reconfigures their whole neurocognitive state, you begin to realize two things. First of all, we've ignored people for too long and haven't really built what they said into what we do. Secondly, we've rushed to biomedical treatments like drugs rather than thinking to ourselves, now hold on a minute, there's something going on here in this person's whole cognitive relationship to the world. Maybe we need to attend to that first. Maybe the casual chat when you come into the GP's office is heaps more important than actually we're ever taught formally by psychologists or some of the more scientifically and neuroscientifically minded teachers we have at med school.
Yeah, I think I kind of agree with you. I think there's a really interesting shift in discussion, you know, around depression, for example, at the moment, around thinking about that primarily, or starting to question about whether that is primarily driven by social isolation, for example, and disconnection with other people, as opposed to some, you know, biochemical state, as you said. And I think the thing that I like about the epistemic justice frame is just really emphasizing how people's interactions, particularly from a position of power, a clinician's interaction with a patient, every interaction has the opportunity to kind of uplift that person and make space for that person and to enhance that person's mana, or to dismiss them. And it's the cumulative cost of many of those interactions often.
And one thing I think we need to remember too is that, you know, a lot of the perspectives and understandings and ideas are from a very Western kind of framework with Western lenses on, right? So if we look at different kind of cultural perspectives of care and around care and wellness and illness, then things can shift quite a lot as well.
Thank you both. If no one else has a question, I might just put one myself. So Kate, I think this is mainly a question for you, but Angela, you may have thoughts on this too. Since the birth injury has been recognised by ACC, and alongside that, as you mentioned, Angela, the sort of conceptual understanding of what constitutes an accident or an injury or whatever has got, that goes with that. Have you seen, Kate, in the area that you work, any significant changes since that change at ACC was made, or that recognition was given to this form of injury?
I wouldn't say it's dramatic yet. I think that the people who kind of know about it now as a result of those legislative changes already knew about it, if that makes sense, in terms of healthcare practitioners. One thing that I will kind of say, it's brilliant that it has changed, because it says that this is an issue, it has been an issue, significant issue, it is an issue, and it's an issue to the point of we will make legislative change and we will offer these supports to people. It certainly doesn't go far enough. You know, when we were campaigning for these changes, we kind of campaigned for 100% and, you know, got 13 kind of thing, but haven't seen a significant change yet. But I think that's probably something which will quietly grow in terms of people's understandings and attitudinal shift and so on. And I'm, in terms of you know, speaking of kind of quiet attitudinal shifts, I'm mindful that the work that Angela and I and the organisation are doing is that slow change stuff. So it's changing, working at chipping it away at those attitudes of, oh, well, she'll be right. Well, you know, what do you expect? It's just birth and that kind of thing, whether it comes to physical injury or psychological harm.
Thanks, Kate. Ben, I see you have your hand up again. Do you want to do a follow-up?
Just a very quick comment. This arrived in the mail yesterday. How to treat maternal birth injuries. So New Zealand Doctor has never had a guidance on how to treat maternal birth injuries before, and it's just arrived. So
what's
there is
the
a small
publication?
tip. This is New Zealand Doctor.
A New Zealand Doctor, yeah.
So, you know, things have moved a little bit.
Yeah, and that's a result of the that'll be ACC media team right there, which is great to see. Yeah.
Thanks very much, Kate. Yeah, we probably have time possibly for one last quick question, if anyone has a burning question they'd like to put to our speakers before we let them go. Mike, go ahead.
Yeah, I just wonder whether there's anything, whether there's other, this has made you wonder about other aspects of medical care. Like I was just thinking, there are some similar aspects, I think, in the labour process, perhaps to perhaps rehabilitation medicine or something like that, where people are sort of often encouraged to do things that are painful, and perhaps their self-reporting is not taken seriously and things like that. And I just wonder whether that could be a source of information that's useful for you, or whether you've discovered that it is, or whether this is something that could be the sort of thinking that you have there could be applied to that area as well.
Yeah, I think there's definitely,
Okay.
sorry, I was going to say there's, I certainly haven't looked at other medical experiences, but I think there's definitely threads that weave through many other kind of medical experiences and health experiences that are really strong in the birth trauma space. Yeah. Go ahead, Angela.
Yeah, I was going to say, I think there's a few threads there. So I think your point about like it's rehabilitation is something where the subjective experience is really important, right? And it might be kind of hard to quantify that in terms of biomarkers that can kind of be objectively assessed. So anything that's more subjective, I think there's more room for over prioritizing a clinician's view and like discounting embodied experience. Pain is another really important theme, and pain, because it's subjective, is open to disproportionate influence of all those biases that we talked about, right? So there's biases around like perceptions around African Americans' pain and stuff as well that has an impact there. So I think the pain theme is really important. But what I think is unique about labour is because there's a fetus involved, then it fits into that whole, and there's a whole kind of debate in obstetrics around the 2-patient, 1-patient model, which is completely unresolved and open-ended. So what's going on there is that midwives and obstetricians and clinicians feel like, understandably, there's a dual obligation to get the baby out in a healthy way and to respect the mother, and it happens in kind of a short, sometimes longer than we'd like, time frame, right? So this sort of the tensions of all of that happening at once, I think, bring it to a real head in relation to labour. But I think there are common themes, and it's really helpful for you to have pointed those out. Things.
I just add that the reason I asked my question is because I think fertility medicine and abortion are two areas where so many of these things are still there.
Yeah, couldn't agree more.
Yeah, I think in abortion care in New Zealand, my experience of abortion care and working with providers is that is actually one of the best, most patient-centered, wraparound, multidisciplinary. No, shaking your head. You don't think? That's my experience in Wellington, the team in Wellington, in terms of the social workers and stuff. But are you thinking like in terms of the referral process as well, or like the providers?
I know someone who had a late abortion and was induced, and that was a terrible experience because had to labour in hospital but treated as kind of like not really a proper labouring mother and all that kind of stuff. Just an appalling experience. And it's like, well, you don't want this baby, so why are you claiming there's no suffering here? And it was just so bad.
Oh, that's awful.
I don't think it necessarily goes well.
No, that's probably you're absolutely right. I think I'm talking mainly about the vast majority of abortions are earlier abortions in New Zealand, and would happen in an abortion clinic. But definitely by the time you get to those later term abortions and you're dealing with care provided on a general ward, the cultural dynamics quite different. So I guess what I'm talking about more is like the cultural provision of abortion care within an abortion service, I think is actually quite very patient focused. But that's awful. Yeah.
Well, we're at time, and I appreciate that there's much more we could say and talk about, and you both have great expertise to bring to this topic. So it just really remains for us to thank you both for your time, for joining us from far distances and time zones. So really many thanks for such an interesting and insightful talk. Thanks to you both.
Thanks, Kate.
Thanks for having us.
Thanks for coming and joining us.
Great day, everyone.
And we'll see you, hopefully see people next week for a seminar from Jingbao. So thanks everybody.
Bye.
Hey, from Singapore, you might